say this to people often that if you find a good psychiatrist, it's like finding gold. And Dr. Comrade is one of these. I've had the pleasure of knowing him for many years. He is the author of "You Need Help: Step-by-Step Plan to Convince a Loved One to Get Counseling." What you can find at www.youneedhelp.com and on Amazon as well. Dr. Comrade, welcome to the show.
Thank you. Thank you so much. And
And
I
I
do want to take a moment to say that you and your services and your team are one of my secret weapons.
well, you're
In
that's very kind to say.
terms of some of my toughest cases that really need far more than what I can provide them, I turn to Todd Weatherly and Associates. You have been able to really change lives for some of my patients, and I thank you for that.
Well, thank you for saying so, Dr. Comrade. But we need guys like you out there, of course, because sometimes they need intensive work, but I think the real work gets done in community with people like yourself who are just can be with people through their journey and through their process. And I'm so grateful that you're out there serving the world. So the thing I'd like to know is what brought you to write the book, which I give that book to so many of my clients. I'm like, you need to read this book. I'd watch a little video, Dr. Key, like I'd send your stuff out to people all the time. And the feedback they give me is like, oh my gosh, they feel less alone
Yeah.
in their process of getting a loved one to get help. What brought you to writing this resource that we have?
Well, I'm glad you're using the book. Also, NAMI uses it quite a bit in the family to family course.
I'm aware. It's really cool too.
So the book really emerged out of my experience as a radio talk show host.
No.
Yes.
What?
So
How did
in
I not know that?
well, I'm not. I don't know whether I wrote about it in the introduction or not, but in basically in the late '90s and early 2000s, I had a radio show, call-in radio talk show about psychiatry, 2 hours every week that broadcast to 43 million listeners all around the country and actually also on the Voice of America. So it was broadcast abroad. Interestingly, my biggest audience was actually in California and Hawaii, even though I'm in Baltimore. So each week I would have a 2 hour call-in show. And usually for one of the hours, I would interview a colleague about some topic in psychiatry, anxiety or PTSD or schizophrenia or any one of the number of interesting focus topics that one could talk about with a colleague, and we'd take calls uh, from listeners. But the second hour was always open phones. Uh, I called it anything you've ever wanted to ask a psychiatrist but didn't have the time.
Use your time.
Uh, so now you got an hour. So that would, of course, be the most popular hour for call-ins. And many of those call-ins, people were invited to ask me anything they wanted to about mental health, about treatment, about the system. Uh, People would call in frequently to talk about a loved one, my mother, my uncle, my son, my closest friend, my spouse is clearly troubled and troubled at a level that's beyond my understanding and my capacity to really know what to do with them. How do I convince them to, to consult somebody like you? So, a psychiatrist or other mental health professional, so that we can figure out what's going on and maybe begin to address it um, with whatever the state of the art has to offer. So I brainstormed with people about their situation on the air, uh, hundreds of people that I did that with. And ultimately, because of that experience, that kind of became like a specialty, one of my specialties. And people would come both locally, nationally, and internationally to have a consultation with me about a loved one who had some kind of clearly psychiatric problem that they may not know what to call it, but they needed help. And so after 20 years of doing those consultations, the radio show lasted 4 years. But after 20 years of those consultations, I put everything that I learned over the course of doing that into this book, You Need Help, a step-by-step plan to convince a loved one to get counseling. Because, we talk a lot about how difficult it is to deal with the current state of the mental health care system in this country. And we talk about things like inadequate number of providers and inadequate funding and inadequate resources and residences and treatment centers. But really, prior to all of those problems is the toughest part often, which is actually convincing somebody to get the treatment that they need. Because in psychiatry, the, the willingness to access treatment is much different than in any other field of medicine.
Absolutely.
We don't have books, how to convince somebody to see a cardiologist or to see an orthopedic surgeon about your knee, right? Or an obstetrician about your pregnancy. People are, ready, willing, and able to typically, if they can, access those other kinds of medical specialties. But in my domain, in my wheelhouse, people are often very reluctant to. And there are many, many reasons why they're reluctant to. And as a matter of fact, the longest chapter in the book, which is chapter 3, is going through a variety of reasons why people don't get help, why they're reluctant to. And those reasons range from those practical things like not being able to find a person available or pay for it to some of the more abstract reasons like stigma and denial and the way in which people feel that in our culture that problems in mental life are problems that one should solve for oneself. And that the idea that the mind and the brain might actually begin to malfunction in a way that might require more than just self-reliance is actually a very difficult idea for most people to metabolize and understand.
Do you think that's a post-war thing?
A post-war thing? That's an interesting question. I actually think, and I talk about this in the book, I think it goes all the way back to the origins of our nation, which are grounded in Puritanism. The earliest pioneers who came here were the Puritans and people escaping religious persecution. They were pioneers. So by definition, the culture was about self-reliance, about competence, about self-actualization. We don't need the King of England,
Yeah.
anymore.
Yeah.
We don't need the Pope anymore. So I think that the puritanical roots, industriousness, productivity, and independence and freedom, which really are very much woven into the fabric of our country, I think are some of the deeper reasons that percolate in our culture.
We've been carrying it a while, is what you're
Right.
saying. Yeah.
And of course, the stigma about mental illness is far older than this country. I mean, that goes back, thousands of years to, seeing how the mentally ill have always been, alienated and disenfranchised and treated as, not just strange, but sometimes, as dangerous, possessed, and so forth. In the early 20th century, psychiatrists were called alienists because we dealt with the alienated from society. That was
Alienists.
alienist. Matter of fact, there's a wonderful book that was turned into a series on one of these streaming services called The Alienist that looks at.
Oh, I haven't seen it, but I've seen the name pop up.
Well, it's a very interesting series.
I'll have to check that out. Well, you taught me something today. I didn't know about the alienist, and I love the point about we've been carrying this a long time. And the reason, you think about post-war, and it was kind of, you huddle together and you find your resources and you carry on and you don't complain.
Right.
You've got the boomers and the greatest generation, and that was the message that people lived with.
And, I think that although I think we've made a lot of progress in stigma, I
Yeah.
think it's still very much there. As you can see from the book here, let's see if I can hold it up.
I can see it. Yeah.
Yeah, okay. So you see the foreword was written by Rosalind
I
Carter.
saw that, and you guys are rubbing elbows there on your website. I think that's fantastic. She's
And
a special lady.
I want to, give a shout out to her of blessed memory because first of all, she was one of the very first ladies to have a very specific mission that she tried to deploy herself with throughout her 4 years of influence, and then subsequently. And that was specifically mental illness, and specifically to combat the stigma of mental illness. So she was very kind enough to write the foreword of this book, which, so I stand on the shoulders of people like Mrs. Carter, who's been at this in a very robust way for a long time.
Wow. What a great story. That's a fantastic story. And one that I didn't know. So I'm really happy that we spent some time on the topic. Now the fun question is that what's the magic sauce? What is it that you find really, and I know there's not one way, but like certainly in my work, I end up a lot of my folks are folks, and usually as a result of psychosis of some kind and pretty or severe depression. Their symptomology is really really bad, as you know. Folks that you've sent our way are in crisis, and and a great many of them are, no, I don't need help, you know, but go away. And they're very difficult. A lot of times they have to fall as deeply as they can, hit, as they say, rock bottom before they're willing to receive help, or sometimes even begrudgingly then, but don't have any other options, and that's kind of where they're
And,
at.
and, and sometimes, unlike any other field of medicine, under certain highly selective circumstances, we can actually treat people against their will. I mean, we do not like
That's
to do that. And it is, I want to reassure people that although one hears about it, and psychiatry often gets, painted as the bad guys because of that, rarely it is necessary. And as a matter of fact, the the ninth chapter of my 10-chapter book talks about that kind of
hmm
situation where you have
that's
to,
right.
what I call hardball, and gives you some guidance and tips about what to do and how to steer through the system. So you asked about the secret sauce, and I don't, obviously this is a very complicated topic, and I wouldn't want to boil it down to one ingredient in a complicated sauce. But
But what's the base?
the base, good, the base. All right, let's work with the metaphor. Right.
Work
So
with
the
this
base
metaphor, right?
is the empowerment of the family. One of the things that, as I've consulted so many cases where things have, are stuck and things have failed to progress, my general observation has been that the loved ones, typically family members, is the typical scenario, have underutilized the power that's inherent in the family. Uh,
Mhm.
that they have not really deployed all of the power that a family has to steer loved ones through the mechanisms of both emotional influence, both rational and inspiring influences, as well as through the mechanisms of family privileges that go along with being having the responsibilities of being a family member and responsibilities of self-care. So the book really progresses from the most introductory conversations about how to have a facilitated, influential conversation to try and point out what are some of the concerns and what are some of the options, and how love is fundamentally the point of departure, because that's something families can offer and can use for influence, and is there indeed, their starting point in a way that I, as a professional, mental health professional, that's not where I'm coming from. Although, of course, I love my patients, but that is not my point of departure. Is my experience and my expertise. But a family's
Right.
point of departure is love. So we start off with those conversations and gradually try to bring in others who may be of influence, primary care physicians, coaches, teachers, clergy,
People
uh,
of trust. Yep.
people of trust who can join the conversation of influence. Uh, but ultimately, it may require going even further. And what we eventually may have to end up on under some situations is what I call therapeutic coercion by families. And there's been other terms for it, tough love, uh,
Right.
for example, right? That the family can begin to utilize some of the privileges that they have been dispensing to their loved ones without any expectation of return, particularly any expectation of return in this particular channel, which is, getting treatment. And so that that becomes, difficult. That's very difficult. And what I often find is that, you know, the the flip side of love, because it's the same coin, is enabling.
Yeah. I think that's
And
true.
and I think all enabling begins with love. It always has its origins in the best of intentions, in trying to do the right thing and coming from a compassionate place to try and spare your loved one the agony and misery of their affliction. But it often ends up becoming counterproductive, paradoxically.
And the
Uh,
line is imperceptible, I think, to families
it
too.
is. It absolutely is. And I always, when I start to get into this, I always do want to make the point that you started that out of the best intentions, out of love, out of caring and compassion.
It's
So,
what you knew to do at the moment.
right. So that is an important thing to begin to recognize how you might, as a family, have inadvertently enabled the situation, the status quo, have inadvertently tried to deploy privileges that have actually ended up stymieing the unfolding of treatment and the progress.
Hmm.
So we have to kind of go back a step to think about the idea that with privileges come responsibilities, and and the most fundamental responsibility of a family member is actually self-care, particularly of an adult family members. And many of these scenarios that I deal with are young adults who are just beginning to emerge into what is often a major mental illness, which, as you know, typically begins between ages 18 and 25 as a common, which is a very delicate transitional time of life, right? It's a time of life where you might be launching yourself for the first time, perhaps in a more limited way to college, right? Or your first job, perhaps beginning to get into your first adult relationship. Uh, and for many of these young people, their illness has kind of hijacked those
Oh yeah.
those progressions,
And the
and so,
maturity gets put on hold,
right.
you
So
know.
they're stuck, and they turn out to become very dependent on their family, which is unfortunate, but it's also good news for this project of trying to get them treatment,
Right.
because that means you've got a lot of power, right? They're not paying rent. All right. Well, what's rent? Well, rent is you need to go and get an evaluation. Rent is you need to follow the treatment plan. Rent is you need to stick with medication if that's what the treatment plan is, or other kinds of therapies and interventions that are possible. Um, we're giving you free cell phone. We're giving you free internet. We're paying your car insurance. We gave you a car. Um, Doing your laundry. and so on and so forth. But that's the point that generally we're really past the point of being able to utilize rational persuasion.
Yeah.
And unfortunately, there are illnesses which have very much interfered with the capacity for rationality. And so at that point, the ability to persuade, look what you're subjecting your spouse to, your children to, look how you're jeopardizing your job, by missing so many days of work. There comes a point in the evolution of certainly serious conditions where there is a loosening of rationality. And indeed, we may even be getting to the introduction of both irrational, irrational, and false thinking, delusion,
And even delusional. Yeah.
hallucinations, and so forth. And it's at that level where persuasion really breaks down. And that's really where we start to need to get into coercion.
Yeah. Well, in any form of, trying to negotiate and trying to do these things, there is a saying, it's not you can tell me if you've heard this before, but even on the psychiatric floor, everyone knows where the fire exit is.
Mhm.
And you
Right.
you have to kind of dig deep for it, but it's like, look, you've been living this privileged life and you're unwilling to get help, so we're going to start cutting those off a little bit at a time. I hope that you'll see that you have a way of exit, but that way of exit is to get treatment. And
Right.
it's
Now, the other thing that I often try to uh, persuade families to do is to not shy away from calling the problem what it is. Uh, I think that being able to address the idea that we think you're ill, we think that your mind isn't functioning well, we think that your brain isn't functioning well. You may disagree with us, we understand that, but we have been educated, we've consulted with Komrad or others, uh, and we've come to recognize that sometimes when the mind and the brain start to misfunction, that the person can't recognize it, but we can. We do recognize it, and we want you to know that we're trying to get you help. We're trying to get you treatment for an illness. We don't know exactly what the kind of illness is. In fact, that's why we need to consult someone with expertise to tell us, because after all, you can't treat until you know what you're treating to figure out, what is this, what's going on. Diagnosis is a necessary prelude to therapeutics.
treatment. Absolutely. Um,
So, stigma notwithstanding, we've got to be able to give some name to this, because once we give a name to this, we can dip in to all that we know about what to do for people who are having that kind of problem.
well, and I think the other power to that I'm glad you're saying it is that families that don't know or at this the process and haven't received help like yours, say for example, they try to process it and they try to rationale and they try to reason. Um, if they get with you and you give them that advice, it's okay to name this. It's okay to call it what it is. It also prevents you from falling into the let's process the delusion or the sickness with this person. It's like this is not right. You need help. That's our stance, and make it really clear and make it really simple, and not fall into the trap of these kind of perpetual patterns that families seem to have. You know what I mean? So it sounds like now we've added flavor to this sauce. We've
I teach my residents, uh, always try to argue a person out of their delusions. Why? Because I want them to learn that you can't. Uh,
yeah.
in, indeed, by definition, right?
Tricky. That's tricky of you.
Right. A definition, the definition of a delusion is a fixed, false, idiosyncratic, you're not sharing it with, everyone in your church, an idiosyncratic idea that is space occupying. It dominates your mental life and affects your behavior. I mean, kind of like a tumor that pushes aside the normal tissue of life. It is space occupying in that in your mind. So by very definition, you can't argue with a delusion. And in fact, one of the interesting things that often my residents will discover is when you try to argue with a delusion, it kind of is self-justifying. So if you point out inconsistencies, the person will find a way to show you why that inconsistency is not inconsistent, or roll you into the delusion, saying, look, of course you're telling me that that's false because you're part of it.
It's
You're
quicksand.
you're supposed to tell me
It's
that,
like quicksand. The more you
right,
fight it, the deeper you sink.
exactly. So rather than fighting it, we reframe it, we work around it and say, we understand that that's what you believe. We think that's your illness talking. That's why we're trying to get you help. And let's find out. We could be wrong. We could be wrong, but we're not experts in this. And also, we need, because clearly you're troubled. You haven't been going to school, you haven't gone to work in months, you haven't showered, in days. You can't stop washing your hands. You stand at the sink for 2 hours to wash your hands. Uh, we need to learn as a family not just how to help you, what to do, but we also need to learn what not to do. We don't want to make things worse for you because we really don't know what we're dealing with. We might inadvertently, make things worse for you. So we all have to figure out what's going on here and how to find your way out of it, because you're clearly miserable. Maybe we're sharing the misery with you,
Right.
and we have to find our way out. So for all of us, we need some do's and don'ts. And so the consultation is not just for you, it's for us too.
Now, by the time they get to you, you may run into this problem because somebody does an initial call or something. I run into it fairly often, which is um, the family they've reached you. There's a scenario going on. The person seems to be getting worse, but they're not sure or they haven't had contact, so they're going to wait. And my advice to families is, I, even if you feel like you're not getting anywhere, don't stop trying something. Keep Stay in contact. Keep like text them, phone call them, stay involved, and don't just wait off on the sidelines for something different to emerge because the chances are good what emerges will be worse, not better. And I don't know if by the time they get to you, do you encounter that with clients who are trying to make an initial
Well,
consult or
yes,
what have you?
absolutely. And I have a picture somewhere in my office that says, "This is not what success looks like," which is a straight line with an arrow. It's a curlicue all over the place, and eventually an arrow.
It's great.
It emerges from
I
the
need a
knot.
copy of that. You got to send me a copy
Yeah,
of that.
yeah. I share that in some of the workshops that I do about my book, uh, and that uh, a lot of families say when we talk about some approaches, they say we tried that and it didn't work. Well,
Right.
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 Well, did you try it again? Did you try it again with a little different twist? So it's very important for people to understand that this is a project. And it's a project that may take some time, takes some effort, it may take some creativity, it takes allies to do that, it takes support. By the way, I often advise families that, look, you're clearly suffering. Why don't we get you some help, right? And get
Absolutely.
you some therapy and some support, and other kinds of help, like, for example, another one of my secret weapons, NAMI, the National Alliance for Mental Illness, which, as I said, at the headwaters runs this wonderful program called Family to Family,
One of
in
their best
which,
resources.
right, so other family members who have been through this are trained to teach a curriculum to new family members about everything from A to Z, the basics of the brain and mental illness and how to work the system and insurance and everything, and tell anecdotes about some of their own struggles. And very often at the end of that class, which is typically free, at the end of that class, the families who have come together to take it continue on together as a support group, uh, as family peers support group. So the family may need that support, but do not give up. That you cannot take the one and done approach on this, and you have to keep at it. Now, sometimes things are too acute, right, to be able to do that, and so families need to know about acute resources under those circumstances. What kind of acute resources? Well, where the local shelters are, for example, right? Uh, and if the family power is insufficient and it's an acute situation, how to mobilize powers beyond the family. I really want to make it clear that mobilizing powers beyond the family, I consider a last resort, not a first resort. Uh, I want you to try, we're going to try the following 50 things first, over and over and over again, unless it's acute, right? And then you may get to the point where, especially if things start to look dangerous, then you're going to need more muscle in the form of authorities, whether judges, police, emergency rooms, hospitals, uh, and the due process that all of those things involve.
It's a tough thing for them to go through, I
Right.
swear.
But meanwhile, even before you get there, you may need some other resources, not just these support systems, but resources like where the local shelters are, uh, how to how to deal with the threat of violence. By the way, another thing that's a last resort, but it's on the list. The ultimate privilege is housing.
That's right.
And right, and that may be, and that's a very big step, and it requires a lot of support to do it. But at the end of the day, that may be the only privilege left. And I have to tell you that often works. That
Sure
often
does.
works. I've had many, especially young adults who've spent their first night out under the bridge. Again, not a first step, right? That's graduate school in this program, not
Yeah.
not elementary school. But that, which is, look, we will be glad to support you in these ways, pay for things in these ways, but we're not going to pay for things in those ways, right? We're not, we are prepared to pay for treatment. We're prepared to fund, if we can, because it tends to be pretty expensive, residential therapy, residential treatment, something you specialize in and helping families find. We will house you, but we will not house you in our home.
You're in your apartment.
Or your independent apartment. We're not going to keep paying the rent and paying your gas and electric bill and paying the landlord to fix the holes that you're making in the wall.
Right? Or the mess that you're making on the floor.
Right. And you may have to get evicted, and we're still prepared to help you with housing, but one particular kind of housing. We've been the independent housing route, been there, done that, got the t-shirt, right? and now it's time to try something else. Sometimes I'll use a metaphor. We've been all over the table, right, in trying things with you, the XY plane, right? Now it's time to go to the third dimension, the Z axis, right? we're going to try something different because we've been to every inch of this table. Now we need to look at a different perspective
Yeah.
to go up. And that different perspective is professional help or residential treatment, or in rare cases, hospitalization, or radical things like changing the locks on your door. And
Hospitalization is less and less rare these days.
well, yeah, and unfortunately, um, it's also less and less accessible. And I'm sure you're aware that the number of inpatient beds for psychiatry are woefully inadequate. And it is not unusual for people when they go to the ER, even voluntarily go to the ER, to spend a long time, days, sometimes in the ER. Particularly, there's a tremendous shortage of child psychiatry beds. And so here in Maryland, we shamefully have had some infamous cases where some children have been brought to the psychiatric ER and kept in the ER for several months.
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 Wow.
You put it right, waiting for a bed. As a matter of fact, the Maryland legislature just made a huge grant to build more child beds in Maryland. And it actually was stimulated by some very incendiary newspaper articles that detailed some of these awful cases. So that's, you know, the mayor of New York City said, we're going to get serious about the mentally ill, and we're going to encourage our police and other authorities to have a lower threshold for bringing seriously mentally ill people on the streets and the homeless to the psychiatric emergency room, right? But then what's going to happen with them in the emergency room? I mean, all the beds are full, right? So if somebody is not imminently dangerous to self or others, which is the requirement for retaining them, a very, very high threshold for depriving someone of their civil rights in the interest of treating them,
Right.
They're going to be discharged back to the streets again. Or
They are not well.
right. Or if they go into the hospital, if they're lucky enough to get a bed, they'll get stabilized in the hospital over 5 to 8 days. And then where are you going to send them? First of all, are there outpatient psychiatrists available to treat them who don't have a waiting list of 3 months?
Oh, and
Right?
by the way, we're only going to give you enough beds for the next 24 hours.
Exactly. And we're going to have to, you'll have to apply for Medicaid with somebody who's going to need to help you with that. And where are we going to send this person in terms of where can we get a roof over their head? They were homeless to begin with. Well, we got all these shelters, and the shelters are completely full. So, it's a fool's errand what the mayor is trying to do, because it's a front end approach without any significant investment and development of the back end, which is where the real action has to take place in treatment of these conditions.
Before we have to go, I got one that I would like to get your thoughts about, which is about this very topic. Deinstitutionalization back in the early 70s. There were a lot of people who were kept put in psychiatric wards inappropriately, stayed there for under very terrible conditions, and then one day were just released, which was a terrible thing for them to do. But the thing that they laid down was this, the criterion, imminently dangerous to self or others.
Right, but I do want to say that back then in the institutionalization, that was during the um, um, who was before Reagan having a mental block, the administration prior to Ronald Reagan, Nixon. So they had the Community Mental Health Act.
Right.
So the institutionalization was accompanied by outpatient clinics, psychosocial rehabilitation programs were set up. It wasn't great, but there was indeed a network to receive people, as well as supervised housing programs. And then Reagan came along, and in as the fashion characteristic of his party, cut it all. And that really caused at least federal funding for it. And
Right.
states had to pick up the
Oh,
funding. Some
we were
states,
wrong. I was wrong. It's not Nixon. It's Bush. Bush,
Bush,
Reagan,
I'm sorry.
Bush, right?
Right. Well, let's
Right.
see. Right. GW. No,
Yeah.
the
Yeah.
original first George the first,
First George.
King George the first. Right. So, so unfortunately, it was simultaneous with the discovery of, fairly effective pharmacotherapy for a lot of these serious conditions that really enabled even the concept of deinstitutionalization. However, institutions for the mentally ill were asylums sometimes in the good sense of the word. They they provided protection. They often, I mean, some of these big state hospitals, they had, patients engaged in farming, in working in the kitchen. They had radio stations. They had, hairdressers. They had baseball teams. I mean, I don't want to paint too rosy a picture, but it was a community, and they were integrated into a community. When they were deinstitutionalized, they lost a lot of that. They had to somehow integrate into the community of healthy people, which of course there were many, many barriers to, right? Healthy.
Right.
I used to say to people on my radio show who would say, "Hey doc, what gives you the right to say what's normal?" And I would say, "Oh, I got a good definition of normal." So, well, what's that? I said, "Normal is just somebody you don't know very well."
That's great.
So what we've ended up with is not just deinstitutionalization, but eventually trans-institutionalization. Namely, so many of the people that were institutionalized who became homeless, who became nuisances, who got involved in various misdemeanors that got them into the legal justice system, many of them ended up in jail. And now, do you know what the largest inpatient institution for psychiatric patients is
Prison
in the
system.
country? The LA County Jail.
Yeah,
The LA County
absolutely.
Jail, the majority of people in the LA County Jail have significant mental illness, and the number of those people is greater than any single psychiatric hospital in the United States. So they've been trans-institutionalized.
You haven't, but I have. Do you know what it takes to try to get a 5150 in California? It is like passing an act of Congress. I swear. So the question I have for you is, do you think uh, criteria for involuntary commitment, or at the very least, because if I walk, let's say I was having a panic attack and I tried to go to the psych ward to get help, they might throw some meds at me, but they're going to turn me away because I don't meet criteria. And I can walk and say, "Hey, I want to end my life," and then I meet criteria. So criteria is not just involuntary commitment. It's if I'm seeking help as well. At least that's the way it is where I am and surrounding. And do you think that criteria should be rewritten in a more
Well,
sophisticated manner?
in some states they have been. It's a very tricky and delicate matter, right? Because when you're moving the fulcrum on which balances, you know, the the unjustified with the justified deprivation of people's freedoms,
Right, right.
independence, you're going to get a lot of false positives and false negatives depending on which way you move, right?
Hmm.
If you make the criteria looser, right, then you're going to end up having a lower threshold for involuntarily treating people and get a lot of people who probably should not have been included. But if you move it in the other direction, you make it too strict, then you'll lose a lot of people who really should have been involuntarily treated. So it's tricky because it's a trade-off, right? There are no solutions in life; there are only trade-offs. So now I have some colleagues who disagree with me on this, but I actually think that uh, the language for involuntary commitment statutes uh, should not merely be imminent danger to self or others, right? So each of those things, you can reflect on. It has to be imminent. So thinking that somebody might stab somebody in it, if this keeps going in a few weeks, that's not imminent, right?
Right.
Imminent, dangerous, okay, to self or others. And you can imagine, arguing over, well, what's dangerous?
What's
I think
dangerous? Right.
that a third criteria that has been used in some states is gravely ill. And you can also imagine that's a little bit fuzzy too, but gravely ill, that their illness is so severe that they are not able to adequately meet their basic needs as a
Right.
result of their illness. And I tend to favor the states that have gravely ill. Maryland, where I am, has tried to get there, and it's been, somewhat opposed. I will tell you that my psychiatric society, the Maryland Psychiatric Society, has tended to be opposed to it. Right? What the Maryland Psychiatric Society says is that the problem is not the criteria. The problem is the uh, the system, and particularly the administrative law judges who have to make the final decision as to whether a person is going to be retained. Because
Right.
after you go into the hospital involuntarily, you have to have a hearing before administrative law judge, that they are improperly trained and that they're not using the criteria that already exist adequately.
They're not, well, that's not inaccurate. Now, here in North Carolina and certainly in our county, one of the things that happens is you have to go to a magistrate and they have to approve of the involuntary commitment order. They approve, send the police out and go out, but the order has to be upheld by a psychiatrist. So in that case, you've got somebody who is trained and qualified to make the determination. I think that that's a good two-layer system. Sometimes getting through the magistrate can be difficult.
Right. And then after the psychiatrist upholds it and they get admitted, don't they then, within a week or 10 days, aren't they entitled, if they're still in the hospital, to an administrative law hearing where
Yes.
a administrative law judge decides whether they meet the criteria? And typically, there is uh, typically a public defender appointed to the patient whose job is to argue vociferously as to why the person should be released. And in fact, in this chapter here, so I have here in this kind of situation where we're dealing with emergency rooms and involuntary admissions and so forth. Uh, I've got a flow chart here,
Uh-huh.
and
Yep.
you don't have to see the details.
I've shown that flow chart to families. I'm
Yeah,
like,
see that it's a
this is
flow
where
chart,
we're at.
right? And it tells you sort of what the process is, and it's a little different in every state, but it basically captures the basics of most states. And what I do is I give tips in the book about what where and when a family should show up, and what a family should say at that point, what they should say to the magistrate who issues the emergency petition, what they should tell the psychiatrist or in many cases just a regular emergency room physician,
Right.
what they should say, to present, don't lie, but present the worst possible information, things that you might feel ashamed or embarrassed to talk about, need to present that. And then if their loved one comes up for an involuntary hearing and it's appropriate because they're not better yet, to show up at that hearing, to insist on testifying, to talk about,
The disaster that has
what have
been
been
happening.
the serial disasters that have been happening, and to be able to say, unless there's a significant change in their mental state, in their behavior, we are not prepared to take the person
Exactly.
into our home.
They
So
can't come back home. That's
just
right.
understand, Your Honor, that we've reached our limit. This is beyond our capacity to handle this. So you need to understand that if you release our loved one, that you're going to be subjecting the community to his or her misbehaviors on the streets, and adding to the burden of homeless mental illness. Now, whether you actually are going to follow through with that or not, right? That's up to you. But that's what you need to say at the hearing.
Well, and I think you tap on the other thing here, which is the other side of commitment, which is the discharge. They more often than not happen too early, or if you've got a hospital with a lot of generalists that are in there, and you've seen four psychiatrists in the last 3 days, something ridiculous, and they keep rotating in and out. They don't always agree with one another. You haven't really gotten a good spectrum of med evaluation or med stabilization at all. And then you're going to get saddled with a discharge planner that's going to be like, well, what about outpatient? And the what is accepted as course for a person coming out of a hospital is woefully inadequate for the level of care that they need. And so maybe it's not that we change the criterion, but instead change the due process that is involved before a person is given discharge. It's like, well, you have to participate. You're going to be here in the hospital and to participate in a couple of levels of care, including we know that your meds work, and we know that you can walk out and attend an outpatient session. Maybe that's where it should land. I don't know, but I have as much
Well,
problem with the discharge as the
right,
intake.
but so you're thinking of on the individual level, right? And I agree with you. Now back off and think of it on the public health level, right?
Mhm.
So keeping that person in the hospital a lot longer, as you would like to see happen, now keeps that bed occupied.
You're
And
right.
and meanwhile, the bottleneck of accessible beds from the emergency room. And by the way, it's not just in emergency rooms where people stay, but if you land in jail due to a certain misbehavior, and it's
Mhm.
clear that you really need to be
Psychiatric
an
care.
inpatient psychiatric care, you're going to wait months in jail also
That's right.
until a bed opens us because the beds that are available are the emergency room is given priority to fill those beds, and the prison, well, at least they're in an institution,
Contained.
and there may even be a psychiatrist at the institution who makes rounds once a week. So you're getting something there, but we don't have a bed. So the longer you keep people, the slower the turnover. So it ends up creating tumult on the systems level.
Oh, I'm not saying there shouldn't be money and other facilities involved. You of course are familiar with Cooper Reese and everything else. The urban campus, which I helped open, sits in the place where the Highland Hospital was. Now, Highland Hospital was a psychiatric facility, of course, but it had staged layers all on campus. So you'd have a hospital level, and then you walk over to a step down that was actually connected by a tunnel where you could receive for the next, say, 2 weeks or however long, more care, less acute style care, more therapeutic treatment, stabilization care before you were released. I would, I've seen, and there are private pay residential programs that operate in this fashion. I would love to see us as a public embrace a model that insurance will pay for, that anybody can walk into and say, "Hey, I'm having trouble," and still be able to find a level of care appropriate for them. I know that's a reach,
But
but that's what I'd love to see.
Why did Highland Hospital close?
Well, I mean, Highland Hospital was in the 50s, so it was and it was considered to be the kind of the cutting edge of psychiatric therapeutic
So
care at
did
its
it
time.
get unfunded by the state? I mean, just because we had deinstitutionalization doesn't mean the hospital's necessarily closed.
Right.
But did the state decide we're going to no longer invest in this kind of institution?
Well, I think that what they ran into, and I don't know the specifics for sure, but they ran into the exact same thing that many of the therapeutic programs, including the ones I started off working at, ran into, which is managed care came in and started dictating care periods and care methodology to the hospitals, even though they weren't professionals, or they were, but what they were doing is like, we've taken the aggregate average of what we think is going to be an appropriate amount of time for this person to receive care, and you get 3 days. You've been using 10, but you
Right.
get 3. You
And,
get
and each,
72
and
hours.
each day you have to justify to
Correct.
the reviewer why one more day.
Why one more day? Right.
I want to tell the listeners that thinking about managed care and utilization review and all the things, prior authorizations and stuff like that, that if you were to look at the pie of money that was going into different specialties in medicine, surgery and urology and obstetrics and gynecology and pediatrics and psychiatry, and you look at how big a bite out of the former money that was being spent was taken of managed care, the bite that it took out of psychiatry was vastly bigger than the bite that was taken out of any other field of medicine by managed care.
Hands down, without question. We saw year-long programs turn into 30 and 60-day programs for kids, you know. It was it was amazing. And what it created was the more complex psychiatric child and adult that we see today. And they're getting more and more complex, I think. I don't, would you say that that's true?
Well, define complex.
Multiple co-occurring conditions, various diagnoses, some of which may or may not be appropriate or they may have been misdiagnosed. Lots of really hard to manage behavioral kinds of things, violent behavior, explosive behavior, emotional outbursts, et cetera, et cetera. And stuff, especially for somebody like me, hard for me to find a place to put this person because nobody will take them. Yeah.
Right. In terms of what are we going to do with this person? Um, it's interesting. I gave a lecture at Tufts, uh, and I remember somebody, and I was talking about what are the options that we have available for serious cases. And I pointed out that one of the options that I use as much as I possibly can, which is the world you're involved in, is therapeutic communities, residential treatments. Uh, and that typically insurances will not pay for residential treatment. They'll pay for the whatever clinical care you get there, but there's a lot more expense to residential treatment than just seeing the psychiatrist or seeing the therapist. So somebody got up and said, I tried to get several patients into residential care, trying to convince the insurance company to pay for it because it was very expensive. And I couldn't convince them to do that with my psychiatric patient. But then I consulted on a psychiatric patient who was an inpatient who had liver failure. And this person went through a liver transplant and did okay for a while, and then it was rejected. And then it went through a second liver transplant. And the total cost of those two liver transplants and all the care around was about $5 million. And she said the insurance picked up every penny. And it would not, that same insurance company that I was working with on this other patient would not consider making a dispensation of $50,000 for several months in residential treatment for a tough case that I know would have turned around with residential treatment. So this brings us to the ever popular topic of parity.
Right.
And the great innovation of the Affordable Care Act was it made parity the law of the land. What does parity mean? That if you cover service for one kind of medical condition, you have to cover it for psychiatric condition. So if you pay for rehab, after an automobile accident and you're going to cover somebody for a month in the rehab center, then you need to pay for a rehab in a psychiatric residential treatment center. And in terms of the amount of the insurance will cover, if the insurance covers 80% of the dermatologist, then it has to cover 80% of the psychiatrist right across the hall, right?
Right.
Unfortunately, that though it may be the law, it has not been universally observed.
Practice.
Practiced. It's been observed in the breach, as the saying goes.
Absurd. That's correct.
And there are several lawsuits about this because what it turns, particularly with managed care companies, with psychiatric treatment, they are oriented towards acute care, right?
Yeah.
So we'll pay for 5 days in the hospital, 8 days in the hospital, right? Whereas with diabetes and multiple sclerosis and ALS, they will pay for maintenance care, chronic care,
Hip
and
replacement. My mom
all
was a,
different, right. So and rehab and 14 weeks of physical therapy and so forth, which is not acute care. So that's a way in which, and there's actually one of the major managed care companies basically was found in violation by a court and still wrestling on appeal, that they applied an acute standard to psychiatry that they were not applying to any other field. So it
yeah.
wasn't.
It's an uphill battle. And I've watched people get denied because the person went to the hospital, got discharged, and therefore, that was residential care. And they wouldn't pay for anything else. Now, sometimes you can get outpatient, and that you get the insurance company to participate on that a little more willingly, but it's an uphill battle. We're not there yet. But if we could get insurance companies to cover, residential programs, and we call them expensive. I think people look at figures and they think of expensive, but like you say, here's a liver transplant. Let's call one of those livers $2.5 million. $2.5 million. I can, that would help you treat somebody for an entire year with some of the most complex psychiatric condition and
Oh,
come out the other
more,
side
more,
with,
yeah.
yeah, we could do that easy. And in addition to that, you could stop having them go to the hospital for 5, 6, 7 days. You're paying $3,000 a day at least for that kind of level of psychiatric care. And I've got a client right now in his 60s. He's been involuntarily committed 19 times in the last year. Amazing. Just amazing.
When I first started in this field, which was in the mid 80s and early 90s, I could call up the medical director of an insurance company and negotiate and say, look, if you pay for, give me 4 weeks of step down residential treatment outside the hospital, and I think that's going to save you tens of thousands of dollars, because otherwise this person's going to be back in,
Will.
in a few weeks at inpatient prices, right? And typically, as expensive as some residential treatment is, it's still a fraction of the cost of hospital treatment.
Absolutely.
And they would do that. They would flex. It was called flexing benefits. And I have found over the course of my career that these kinds of insurance coverages have become, or insurance programs have become much, much more rigid. And the ability to negotiate an individual flexibility really has disappeared. And now it's, well, what does the policy pay? We're going to just let's get the documents out. And if the documents say we don't pay for that, then have the patient or the patient's family complain to the employer who issued the insurance, or
Yeah. You
complain
have to take them to court.
take
Right.
them to court. But that's not our problem. That's the insurance this person paid for. You
Yeah.
get what you pay for. And by the way, on that note, you get what you pay for. I think that's actually an important note.
I agree.
One of the things that I often tell, especially when I speak to family audiences at NAMI, I make the you get what you pay for point, because this is America, this is the United States, right? Because one of the things that people often complain about is, um, we can't find psychiatrists, enough psychiatrists to take our insurance, right?
Yeah.
And this is a generalization, and I admit that there are absolutely exceptions to this rule.
Certainly.
But The psychiatrists who take insurance have, because it limits very much what they'll pay, have high throughput practices, right? They may see 3 or 4 people an hour.
15-minute sessions.
And if you want to talk about something other than, your constipation on your medication, I'm sorry, we don't have time for that. Maybe I can find you a social worker to talk about your job or your marriage or something like that. If you have a job, if you have a marriage. So it's very high throughput. The kind of care that people want, that they hope to get, particularly in the domain of mental health treatment, it's very labor intensive, right? So I spend an hour with most of my patients, half hour or an hour. I see 1 or 2 people an hour. I only have about 100 patients. I am available all hours of the day and night. My wife will complain to you that even when I'm on vacation, you can text me at any time. You can email me at any time. If you email me that you need a refill on your medication, I'll probably get it to you within an hour, right? I will meet with your family. I will talk with your teachers. I do both therapy, psychotherapy, and psychopharmacology. So I'm kind of a one-stop shopping psychiatrist.
Yeah.
But I don't take insurance. And that allows me to do that. I only see between 5 and 8 people a day, sometimes 10. Whereas most psychiatrists who take insurance are seeing between 20 and 30
Yeah.
people a day, or
But
they're
billing
working.
them at the same rate that you are for the hour.
What's that?
Billing them at the same rate to the insurance company that you are for the hour.
Right. Well, right. So they're making about as much as I do per hour, but they're making it with 3 people or 4 people per hour.
Right.
Right. And I'm doing it with 1 person. Now, look, obviously everybody can't afford this. And, I have some people that I treat on a more reduced scale. And also in my own practice, when somebody falls on hard times, their fee goes way down. I mean, whatever you can pay me, you lose your job,
Right.
things like that. But you get what you pay for, right? So, and I think that's something important. So I encourage people who are desperate, to get their kids help. Use the college fund, right?
Don't
Take
skimp
a,
on this.
take a second mortgage on your house. Take a third mortgage on your house. Sell your $50,000 car and consider driving a $20,000 car, because that's what it's going to take to be able to get the kind of care that you need. And with residential programs, the going rate, as you well know, is about $20,000 a month. Am I right? 25?
25, somewhere between 25 and 50 these days.
I definitely have lost touch with that price.
And we're seeing 30 being the mark, the average mark these days, and I'm seeing more and more kind of stretch out above that.
Now, but however, there is a little insurance coverage for the clinical part,
There is. That's
right?
right. That's
Doctor,
right.
social worker, things like that. But there's the cost of residence and the cost of the house counselors and the cost of all the materials and the programs and the vocational counselors and all of
If you
that.
get 12 residential days out of your insurance company, you're lucky, and the whole 9 yards. Yeah.
So and there is tremendous pressure. And by the way, there are not enough of us to go around
No,
anyway.
there's not. That's true.
You could really criticize me justly for saying, look, doctor, you're a scarce resource. There are not enough of you. You really should be seeing 40 people a day, right? Quantity over quality, perhaps, but we don't have enough of you to go around, and we have such a need. Why don't you see 40 people a day, 30 people a day, 3 or 4 people an hour? Well, I suppose that's true, but then I can't really look myself in the heart and feel like I have done the right treatment, the right thing for these patients and their family,
I think you're doing the job as it was meant to be,
as it used to be.
honestly, as it used to be, as
Yeah.
it should have stayed, and it became a money game. And I just, Dr. Comrade, I treasure you as a psychiatrist. Just when we find people like you, it's like, I don't know, I don't care how long you have to wait. Get in on this caseload.
And I'm teaching my residents to try to have the same approach. Uh, and I'm teaching them the satisfaction. I mean, look, we all went into our careers because we wanted to have satisfaction, and we have a sense of purpose. We have a sense of calling, in fact. Uh, and we're very susceptible these days, to burnout between all the prior authorizations that we have to go through, the pressures on us for productivity and seeing 3 or 4 people an hour, and the electronic health record, which is a whole nightmare in its own right.
Yeah, it really
Um, it's burnout is
it's high.
something that's very high among physicians. I will tell you that, interestingly, psychiatrists tend to have, as a group, less burnout than most other doctors. And one of the reasons for that is 51% of us do not take insurance,
That's right.
Medicare and Medicaid, as opposed to 2% of surgeons, 2% of obstetricians. The and they're burning out at 10 times the rate as psychiatrists. Now, don't want to have people to have sympathy for their doctors, okay? But we're back to the fundamental principle that, look, some care is better than no care. And I believe me, I believe that if I were seeing 3 or 4 patients an hour, I can do a good enough job to, it's better than nothing, right?
Yeah.
But for really complicated cases, which is the cases that psychiatrists are seeing now that we have so many other mental health professionals in the niche, and social workers and psychologists and licensed counselors and family therapists and
Bestie therapeutic
counselor
consultants.
and nurse practitioners who incidentally have 500 hours of training
Yeah.
compared to 15,000 hours of training for a psychiatrist. And in 28 states, nurse practitioners have identical privileges to practice medicine as psychiatrists.
As long as I've got a supervisor, right?
And in 28 states, after 1 year, you don't need supervision anymore.
Oh, really? Huh.
Yeah.
I didn't know that.
Yeah. So
Wow.
completely independent practice. So indistinguishable. By the way, many people don't realize it because some of these advanced practice nurses they wrote a thesis on top of their training, so they get a doctorate, and they have on their marquee Dr. Smith, Dr. Jones,
Same privilege.
same privileges. And a lot of patients don't realize that, not only are they not MDs, but that the amount of training is vastly different. Now, that being said, a lot of simple, straightforward cases can do fine
Quick
with,
refilling? Sure.
right,
Yeah.
putting them on Prozac, right? Um, Following along, some lithium levels. So as a result of the entry of other mental health professionals into the space, which we need, psychiatrists have been left with the most difficult cases,
Yeah.
most difficult cases, the kind of cases you just can't process in 15 minutes
Or even one session.
or even one session. Right.
Wow.
So that's why one of the things I say in my book also is, if it's possible, when you're trying to get your loved one an evaluation, start with a psychiatrist.
Yeah.
Because first of all, we have the most training.
I would add to that, find a good one.
Right. Secondly, we've been exposed to some of the most severe cases. I mean, we train in hospitals, we train in nursing homes, we train in jail, we train in emergency rooms. I mean, we've had quite a wide exposure. We can think through the widest variety of possibilities about what may be going on here, from things that can be best understood psychologically, from life story, all the way things that have to do with brain diseases and medical diseases that can create psychiatric problems like thyroid conditions, cancers, things like that. So we may, after we evaluate the patient, we may say, you know, I think that this person can do okay with some other resources, does not have to keep coming to the psychiatrist who doesn't take insurance. Uh, this case doesn't belong necessarily, or doesn't have to have this level of care. You know, the Hyundai will get you to the other side of town. You know, you don't need the Lamborghini, right? But there are some cases that really do need that. But when you start with the psychiatrist has access to and knowledge of the most number of different kinds of resources, outpatient programs, day hospitals, inpatient programs, visiting home. You know, we know about visiting home case
teams. Yeah.
ACT teams. Um, you know, if somebody, you know, really needs some primary care, we have primary care connections, right? So that's the place to start. So this project, and by the way, the book basically takes you up to the point of getting that first evaluation. Maybe I'll write another book about what to do after that.
Yeah. Can I write the foreword?
I,
To this man.
indeed, indeed. All right, you're committed. Now I got to commit.
Now you got to write another book.
So
Oh my
the
goodness.
project of getting that evaluation, my recommendation, and I talk about this in the book, why in more detail, try to start with a psychiatrist.
Yeah, I couldn't agree more.
And one whose doctor is an MD, not an NP.
And pay for it. Just go ahead, just pay for it.
Whatever it costs,
Yeah.
even one time.
Yeah. Absolutely. Dr. Comrade, I think we can spend a long time. we
We can
and
enjoy each other for hours.
I think that I think we need our next time that we do this, we'll talk about the new book that you're writing. And so,
All right.
but
That puts me on the spot to commit.
that's correct. It has been a real pleasure. Again, you are a treasure to me and the work that you do. I'm so grateful to have you out there in the world. I'm going to pass this off to people and be like, also read his book. But it's been great to have you on the show today. This has been Mental Health Matters on WPVM 1037, the voice of Asheville, with Dr. Mark Komrad. Doc, thanks a lot.
Thank you for inviting me.
Absolutely.